Hello, my name is Claudia. I'm a ENT and I've been working a long time with tinnitus. Not enough. It's never enough time for tinnitus. There's always something new to learn. So thanks, Rich, for inviting me again. Let's see how it goes. So I'm going to talk about how I see our patient, a little bit about somatosensory tinnitus and tinnitus modulation. What should we look for in these patients? Treatment, and two special clinical cases, very recent ones. So our tinnitus patient is unique. And when they come to our office, we have to have all this in mind. Etiology, the causes. Has the patient been investigated or not? We have to do that. The reactions, like sleep, concentration, thoughts and emotion, and hearing. Myths that this patient is carrying to us, and all the history of trying to treat tinnitus in many different places before he comes to us. Expectations, what kind of patient is this? Is he a curious patient? Is he having a little bit of distress? Or he is really suffering with tinnitus? Does he have a modulation of his tinnitus with muscle movements or pain or posture? And what's his life scenario? What's going on? Is this tinnitus recent, or it has become worse right now because something has happened in his life? And this not really comes easily during the appointment. This is something we have to deal with and search for it and ask for it. So there's a lot of things to do, to ask, to investigate before we do our management. And this is so important. So there's a lot of literature now about these patients that can modulate their tinnitus with some movements, and it changes the pitch and intensity. Usually it's triggered by head or neck maneuvers, this change in tinnitus, and it's caused by a cross-modal interaction. What is a cross-modal interaction? It's the action of two different sensory systems acting together and changing the response of one of them. So it happens in the auditory pathway with the somatosensory input. So as Italo was talking about a little earlier, the dorsal cochlear nucleus is so important. That's the place where the somatosensory and auditory information gets together in the brain in the first step. Spontaneous activities in the dorsal cochlear nucleus can be modulated by peripheral nerve stimulation. It has been a lot of work done in animals, especially by Susan Shore, if you're interested in reading this. Here are some references. And she stimulates the trigeminal nerve. So this is how it works. I have some problems in my neck and head, and this goes to the somatosensory nuclei in the spine. And this information goes to the dorsal cochlear nucleus. It's in Portuguese, sorry. And which receives the activity from the auditory pathway, from the cochleas, and from the auditory nerve. So they get together in the same place. So one might expect that what is changing one might influence the other. So this is a cross-modal integration we are talking about. So during our patient evaluation, what should we ask for in order to investigate if there's this kind of action? If the patient have trauma or neck manipulation, whiplash accidents, dental treatment, braces, put braces, remove braces, chronic pain complaint in the shoulders, in the neck, muscle contracture, trigger points, which are tender points in the muscle that can sometimes refer pain in a different place. Postural features, if the person works in a computer, if she works, I recently saw a girl, she works in the mail and her table is like this and she has to work with the computer like that. And she was, my God, she was suffering. And if the tinnitus changes right early in the morning or after taking a nap, these are some clinical findings that you may ask your patients. You may find a way to get into that. So the physical exam of these patients, we do some maneuvers that have been described by Levine. It's all in the literature. The presence of trigger points, how you do that? You palpate your patients here in this region, in the neck, in the face, in the head. And you also might find muscle tension. It doesn't have to have a trigger point. For example, I press here and I have pain right here. It doesn't have to be present, just the tension. And you can always see that these patients with all this kind of problems with muscles, they can't really move their neck. It goes up to here or there, and you ask them to make this movement, and they complain about pain. So what possible treatments are available for these patients and have been described? Acupuncture, electrostimulation, cervical manipulation, TMJ treatments, medications, muscle relaxants, for example, and trigger point treatment. Now I'm going to talk about two cases. This woman came to me with a pile of exams like that. Everything you can imagine has been done before. Everything. And everything you can imagine has been used as a treatment. Everything. So she has tinnitus and hyperacusis for 10 years. She's a consultant now. She had to leave her job, her previous job, because she had to go to constant travels by plane. And she had the teacher position. She had a PhD. She had to give up because she couldn't stand the noise of her students in class. So she has an ear popping all the time. It worsens during exercises, airplanes, and she put some ear tubes because it was one of the tries of the physicians she went to. They wanted to do that. So, as already I said that, she's isolated. She has aural fullness, vertigo, dizziness, blurred vision, and TMJ problems, which has been treating all her life. The tinnitus handicap scale was 95. Everything in her exam was normal, except for trigger points in the sternocleidomastoideo muscle, trapezius, and masseter. This is her audiometry. You can see it's completely normal. She did MRI, everything, anything you can imagine she has done before. And this is a list of medications that she has tried. So, nothing happened. Case number 2. This man saw me 2 weeks ago, and he had tinnitus for the last 4 months in the right ear. He said, he's not sure, but to say if it started after he had a flu or after the harvesting of tobacco leaves, which is, I don't know if you know how it's made, but the person has to sit on the floor and they have to cut it one by one, and then they move to the other, and then they move to the other. So it's a horrible position. This is his hearing. So I asked him, have you been exposed to noise? Oh, during my job, maybe with the seesaw, is that, you know, yeah, yeah. But he never had a complaint until these 4 months. So I did a palpation in his neck. I did it Monday. This was my second session. This is what is a dry needling. He's not having pain. Don't look like that. It doesn't hurt. Sometimes he might jump. Maybe here you can see the muscle jumping. So I'm relieving the muscle, because when you put the needle in this spot, it kind of holds your needle. So you have to move, and you move until it's released. Then it comes easily out. So I'm still working. And you can see the circulation here, how the blood is moving now. This is one of the things that dry needling does. It increases circulation. So I'm shaking now. The needles are quite easy to remove. So you do these movements up and down. And this is it. So second appointment, first needling, first week, a week before, 50% of tinnitus reduction. And it happens right away. This is something interesting on dry needling, a tinnitus patient. When it has a muscle connection to the tinnitus, the patient tells you 3 or 5 minutes after you have done that, sometimes even before. And how many sessions? How many sessions are necessary? That girl, the first case, in one session, I couldn't believe she started to cry, and she said, what's going on? Oh my God, it's hurting you. No, my ear opened because she had this feeling of the ear was blocked. And when she came back, she said, I'm back to my normal life. I can go out with my husband. I can go to the movies. My life has changed. In her case, I think the change was because of the trigeminal nerve that had been very much compromised because of her masseter, because of her TMJ. And remember that the tympanic tensor is also innervated by the trigeminal nerve, the same one. And what I think that I did was releasing the masseter. I released the information on the trigeminal nerve, also in the tympanic tensor. That's why I think her ear opened, and she's doing pretty well. And once in a while, every 3 or 4 months, she comes for a new session. And this gentleman, I did that, the second one was just last Monday before I came. So I thought it would be interesting to show you how I do that. So dry needling, both superficial or deep in non-trigger point locations, results in changes in chemical, endocrinological, microvascular, neural. These points have abnormal activity, as we find in tinnitus patients as well, in the auditory cortex, and central effects all the way in the cortex, hypothalamus, inactivation of limbic systems, and it has been seen in fMRI and PET studies. So we need, for controlled clinical trials on this matter. Nowadays, there is a PhD student doing one study at University of São Paulo, the university Italo works. And just to let you know, before I got into the tinnitus fields, I really wanted to study something. So I took a 3-year acupuncture course. That's why I'm so familiar doing that. It's not for anyone who just wants to do it.